This is the SURPASS CVOT or cardiovascular outcome trial that we're discussing. It examined cardiovascular outcomes specifically with tirzepatide versus dulaglutide. So looking at two different drugs that are used in diabetes, and these were in fact patients with type 2 diabetes that were studied in the trial, a bit over 13,000 patients randomized to one of these two drugs. And these were all patients who, as I mentioned, had diabetes, all of whom also had atherosclerotic cardiovascular disease. The drugs, tirzepatide, were titrated up to 15 milligrams, and dulaglutide was at 1.5 milligrams. The primary outcome of the trial was death from cardiovascular causes, myocardial infarction, or stroke. The trial was designed as a non-inferiority trial, meaning the purpose was to show, hopefully, that tirzepatide would be non-inferior to dulaglutide. But of course, we planned to also look for superiority. What the overall trial showed was indeed non-inferiority of the tirzepatide versus dulaglutide. Just to give some specific numbers here for that ischemic endpoint that I mentioned, the actual event rates were 12.2% in the tirzepatide patients and 13.1% in the dulaglutide patients. That works out to a hazard ratio of 0.92. That worked out to a p-value of 0.003 for non-inferiority. So non-inferiority was met. The primary objective of the trial did show that tirzepatide is at least non-inferior to dulaglutide. For superiority, the p-value was 0.09. So there was a trend statistically for superiority of tirzepatide over dulaglutide. The confidence in the 95% confidence intervals were 0.83 to 1.01. So it just missed statistical significance for superiority for that triple ischemic composite endpoint. I will add, though, that for all-cause mortality, the p-value was less than 0.05. Now, this paper was published in New England Journal of Medicine, and as people, at least in the trialist world, know, the current approach in New England Journal of Medicine is if superiority in this situation isn't met, you can't then present p-values for secondary endpoints such as death from cardiovascular causes or all-cause mortality or any number of other sorts of secondary endpoints that were examined. But in the case of this trial, if one were to compute a p-value, it in fact would be a p-value less than 0.05. And strictly speaking, because of hierarchical testing and other statistical issues, you can't really claim statistical significance, but I'll just quote the numbers here. It was 10.2% rate of death for the dulaglutide, 8.6% for tirzepatide. That hazard ratio is 0.84 for all-cause mortality, and the confidence intervals go from 0.75 to 0.94, less than 1. So if one did compute a p-value, the nominal p-value would in fact be significant. So to me, putting it all together then, yes, non-inferiority was met against dulaglutide, a very good GLP-1 agonist. But I think the fact that there was a trend towards superiority for the triple ischemic endpoint, and what I'll say is nominally significantly lower all-cause mortality, essentially is a win for tirzepatide. Terrific question. It can be a little confusing, I think, to many practicing physicians what non-inferiority means. What does that mean if non-inferiority was met? I guess in plain English, I would say that means that for cardiovascular risk reduction, tirzepatide is at least as good as dulaglutide. And dulaglutide itself, in the prior REWIND cardiovascular outcome trial, had been shown to be superior to placebo. So if one did the theoretical exercise, comparison of tirzepatide versus a so-called imputed placebo, that is, dulaglutide's better than placebo, tirzepatide's at least as good as dulaglutide, and therefore tirzepatide should be superior to placebo. So had we done a placebo comparison and we had pre-specified this sort of fancy statistical imputation versus placebo, well, then the results are very statistically significant for everything, for the triple ischemic endpoint, for mortality, for a number of the secondary endpoints. And, I think that's legitimate because dulaglutide is, in fact, a very effective drug with respect to cardiovascular outcomes. So, to me, again, this is common sense way of interpreting non-inferiority in this particular trial, where again there were signals of superiority. That is a trend for the primary outcome and also nominally significantly better all-cause mortality. Well, I think there are a few things to say about that. First of all, tirzepatide was more potent in terms of glycemic control, in terms of weight control than dulaglutide. So there are just those practical advantages. Let's say even say the cardiovascular outcomes, maybe you don't buy my statistical arguments or they're seemingly too complex. Let's say the cardiovascular benefits of dulaglutide or GLP-1 agonists in general are the same as tirzepatide. Still, tirzepatide results in better glycemic control in those with diabetes and more weight loss. So, from a patient's perspective, if they need either of those things, that's a useful set of attributes. So, practically speaking, again, let's say cost isn't an issue. Let's say side effects aren't an issue. To me, this shows that tirzepatide is at least as good a choice as a GLP-1 agonist, and in fact, may be better both for cardiovascular outcomes but also because of greater glycemic control for patients with diabetes where that's relevant, and for patients with obesity, there's greater weight loss. So for those types of patients, those benefits are solid, statistically speaking and otherwise. And if you're willing to, think through the statistics in more of a common sense way with me and believe that, then even potentially better for cardiovascular outcomes. And, not to get too much into secondary outcomes in the trial, but had we, for example, in the trial looked at a composite of cardiovascular death, MI stroke, that was the primary endpoint, but thrown in coronary revascularization, as I'll mention, I wanted to do. I did at the initial planning stages of the trial during our executive committee meetings mentioned that I thought it'd be nice to add coronary revascularization in there. If that had been part of the endpoint and had been a quadruple ischemic endpoint, there the hazard ratio is 0.88, upper bound of the 95% confidence interval is less than 1 at 0.96. It would have been superiority in the overall trial. So there are enough positive signals there for me that, if cost isn't an issue, why wouldn't you do tirzepatide? I should mention side effects, though. The incidence of adverse events overall was similar in the two treatment strategies, but there were more gastrointestinal adverse events with tirzepatide than with dulaglutide. So one has to factor that in. But assuming the patient is tolerating tirzepatide and that there isn't sort of a financial penalty the patient is paying in terms of tirzepatide versus the GLP-1 agonist, I would say that it would be the preferred strategy. Well, we specifically studied patients with diabetes. Everyone in the trial had diabetes. So the results apply to those patients. Of course, tirzepatide, GLP-1 agonists are also used in patients without diabetes for obesity and so forth. But the patients we studied all had type 2 diabetes. They had a hemoglobin A1C that was between 7 and 10.5. They also had a BMI, a body mass index of at least 25. Everybody was at least 40 years of age. And they had established atherosclerotic cardiovascular disease in at least one vascular territory. So, you needed to have atherosclerotic disease, but it's not like, it was only patients that had SD elevation MI or some super high risk cardiovascular entry criteria. So I think those results would apply to a lot of patients certainly that I see in practice that have diabetes and evidence of atherosclerosis. So it's a pretty broad segment of the population these results apply to. And I would say, the trial deserves credit, and the trial sponsor also deserves credit for doing a so-called active control trial. That is, this wasn't a trial against a true placebo. In fact, there wasn't a placebo. You've got to do that imputation to compare against placebo. It was a trial against a drug that itself had shown significant cardiovascular benefit against placebo. That's a bold and courageous thing to do. I'll be honest, at the early executive committee meetings, I actually was advocating for doing just a pure placebo trial and going for the total, knockout home run type of effect that I thought would likely be the case with tirzepatide in this population. But the majority of the executive committee, maybe everyone else on the executive committee, and the sponsor both felt that it would be better to do an active control trial because by the time the trial was done, these discussions occurred years ago, that GLP-1 agonists would be in widespread use. And therefore, it may not be as impactful to have done a trial that shows superiority against placebo if the standard of care in diabetes and in diabetes with atherosclerosis had already shifted to GLP-1 agonists by the time SURPASS CVOT were to report out. So that, it's a logical argument. And again, I can't fault anyone for being courageous enough to do a head-to-head comparison, an active control trial. But I also did say if we're going to do that, we probably need a trial that's a bit larger than 13,000 patients or a bit longer than we went in terms of the follow-up in the trial. So, I do believe that if we'd done a little bit of a larger trial or a longer duration trial or both, then there would have been clear-cut statistical superiority for the triple ischemic endpoint. It's a terrific question. From a patient's perspective, they care about MI and stroke and revascularization and especially death, of course. But, those are all benefits that are accrued over time. And if they don't have the event, of course, patients never are aware of the event that they didn't have. That's the challenge with prevention. Even though we may know it's the right thing to do from trials, an individual patient may not appreciate the benefit they're getting from a cardiovascular drug because they're not having an event because of that drug. So, but what they do see is weight loss, and that is a powerful motivator for many patients. Likewise, for patients with diabetes, better glycemic control is often a good motivator. So from a patient-centric perspective, like I said, even if the one says, the benefits of cardiovascular outcomes, it's the same with tirzepatide and dulaglutide, or extrapolating and saying the same as tirzepatide and semaglutide, I'm going to use whichever one I want to or is cheaper, so forth. There is still that extra benefit in terms of weight and or glycemic control that patients will often care about. Now, if a patient's not overweight or not very overweight, or the glycemic control is pretty good, maybe those, aren't as important factors. But for many patients, especially patients with atherosclerotic disease, there's a very high prevalence of diabetes and a very, very high and growing prevalence of overweight and obesity. Again, if cost isn't an issue in patients with diabetes, most of whom require either initially or eventually polypharmacy, if they can afford it, I think it's best to be on something in this incretin class, whether it's a GLP-1 agonist or a dual agent such as tirzepatide. Of course, there are triple agonists that are being studied as well. So I think if a patient can, in terms of cost and side effects, great to be on it. And I think an SGLT2 inhibitor also, great to be on it. A ton of evidence, at least currently, for the most part, especially in places like the US. These are both largely branded medications. There are some generic SGLT2 inhibitors in the US, but they aren't the ones that have good cardiovascular outcome trial data. Generic liraglutide recently became available, but not too many people are actually using it. So I think in terms of the SGLT2 inhibitors, where there's a ton of data in common use, and same with the incretin axis agents, they're currently still typically somewhat expensive. So that is an issue. But assuming that the patient has good insurance coverage, then I think being on both these agents is probably the best of all worlds in terms of reducing cardiovascular risk, with the incretin axis drugs primarily focused on reducing ischemic type events, and the SGLT2 inhibitor type drugs, or SGLT1/2 inhibitor type drugs as well. There's one of those with sotagliflozin, but the SGLT axis largely affecting heart failure related endpoints, and both providing some kidney benefits as well. So if the patient can tolerate it from a side effect perspective, afford it from a cost perspective, I think that's the ideal therapy. And if not, metformin is tried and true, doesn't have the same abundance of cardiovascular outcome trial data as the two classes I just mentioned, but that also is a potential agent that one could consider. So, and then there are other diabetes drugs as well. But typically, the way I sequence things in patients with cardiovascular disease that have diabetes is oftentimes, I'll start with either an SGLT inhibitor or an incretin axis acting drug, depending on whether they have more predominantly heart failure risk or more predominantly ischemic risk, but oftentimes use both.